All right, welcome back to another episode of the IMM Newsletter. As we mentioned, last month was our first month of running a video newsletter rather than the boring old text-based newsletters. So this will be round 2 of those. Love to hear your feedback, either in the comments, shoot us an email. So an update, we are currently recruiting for a new pharmacist to join the team, which we're really excited about. That will bring our current pharmacist numbers to 5. Now, the difference between how IMM operate and other providers is that our pharmacists work full-time for us in the office. So we've got a beautiful space here on the Gold Coast where our pharmacists and admin and pharmacy assistants work from, and our pharmacists therefore have this team mentality where they get to discuss different cases. We have morning clinical meetings where we might have challenging referrals that we're stuck for recommendations to provide to doctors, for instance. This gives the pharmacist an opportunity to bring their thoughts together and come up with some recommendations and strategies that are specific for that particular service. So, clinical update. I want to talk to you guys about medicinal cannabis, obviously a hot topic, and the interstate prescribing that we're seeing with medicinal cannabis. So, what does interstate prescribing mean? What we're seeing a lot of is New South Wales workers' comp or CTP patients being prescribed their usual medications from their NTD within New South Wales. They're also getting medicinal cannabis prescribed by a doctor from a cannabis clinic outside of New South Wales, often Queensland. But in addition to that, what we're also seeing is those cannabis products are being dispensed from a pharmacy in South Australia or a different state and couriered to them in New South Wales. So there's such a disconnect between the cannabis prescriber, the cannabis dispensing, and the NTD and the treatment team within New South Wales. So we have what's called SafeScript, or real-time prescription monitoring of high-risk medications. That records the prescribing and the dispensing of these medications. The issue that we're finding is that this is a state-specific software, meaning that Queensland prescribers can't see what's being prescribed in New South Wales and vice versa. So what we do is join those gaps because we have access to all the state's real-time prescription monitoring, meaning that often we're going to the NTDs with more information than they know about their own patient. So because there's no legal requirements for the patient or the doctors to communicate back to the GP that's managing all of the other medications, it means that we have an NTD that's prescribing often opioids, benzos, antipsychotics. They are completely unbeknown about the cannabis that's being prescribed in Queensland or a different state. Likewise, the cannabis prescriber from Queensland's unaware that this person is using medications that are being prescribed by doctors in New South Wales. So that's a huge issue when it comes to patient management. And unfortunately, when doctors are unaware of this information, they can't make critical, important decisions for their patients. So IMM sort of bridge this gap, make sure everybody's on the same page, make sure that the NTD is aware of cannabis being used if that's the case, make sure that the cannabis doctor is aware of the other medications that are being prescribed if that's also the case, and we can start to rationalise, bring things back to a straight path, unified treatment plans and goals, and then therefore improvements in the patient outcomes through improvements in medication use. So an example of this is what we see in a case study that I want to present to you guys today. So we like to present case studies where it's relevant to the topic that we're presenting. This one speaks volumes to that. We talk often about IMM referral before an IME referral, and this will explain to you why we recommend that so strongly. It's because if the IME doctor or even the treatment specialist team are unaware of the exact medications and things that are being used, how can they make relevant, informed decisions or give relevant opinions on whether the treatment's appropriate or not? So in this instance, it was part of a treatment specialist team where the patient was referred to a specialist. They'd agreed that cannabis was an appropriate treatment for that person, in the fact that the patient had said to the pain specialist that they'd actually been able to reduce and cease the use of opioid medications because of the use of cannabis, in which case the pain specialist was endorsing and supporting the use of cannabis in this instance. However, after the insurer had agreed to fund cannabis treatment in this instance, they then referred to IMM. So when they referred to us, we discovered that not only had the patient not ceased or reduced the opioids, they'd actually increased the use of opioids to a significant level, and they'd been prescribed it by multiple different doctors. When we presented that information to the NTD and the pain specialist, obviously the pain specialist changed their opinion on whether they believed that the cannabis was appropriate or not. They've actually declined the use of cannabis and said that shouldn't be used because of the other factors that were an issue in this particular person's case. So not only did we establish that cannabis wasn't appropriate treatment for this person, it obviously wasn't effective because it had resulted in an increased use of other high-risk medications, opioids, in this instance, but the NTD was also unaware that he was using medications that were being prescribed by a different doctor. Following the recommendations of the pharmacist, the NTD had put parameters in place to make sure that he was the sole prescriber of all medications. They decided that cannabis was going to be discontinued. They were going to reduce it and cease it, even though it was being prescribed by a cannabis clinic. And we were able to put strategies in place to help reduce and cease the opioids over a period of time, whilst exploring other possibilities for pain management. We always advocate for medications being used alongside non-pharmacotherapies such as physio, improvements in sleep and sleep hygiene, because there's a strong correlation between improvements in sleep and improvements in pain perception, allowing for the reduction, cessation in opioid medications. So I think that's a really good example of why IMM needs to be referred to before referring for an IME, or even in some cases before referring for a particular specialist treatment provider. It's because when the doctors receive relevant, accurate information, they can make relevant, accurate suggestions on treatments. So the intention is to improve treatments, improve outcomes for the patient, and therefore return to work and return to life is much more likely. So IMM before IME, and often IMM before a specialist referral, because the information that the specialists receive is relevant to them and it's data driven. So it's factual, it's accurate, and it's not just anecdotal from the patient. So that sort of wraps up the newsletter for June. Would love your feedback on last month's. Obviously this is a little bit raw and basic for now. We will start to evolve this based on feedback from you guys. So definitely leave us a comment and let us know what you would like to hear about for next month. Thanks everybody for your attention, and we'll see you in the new financial year.